So infant hip, so indication. We're gonna rule out developmental hip dysplasia. So rule out. Dysplasia. Other indication potentially could be to rule out or assess for septic arthritis and or joint effusion. So rule out septic arthritis / joint effusion. So we're looking for fluid, or effective fluid around that hip joint. Or we can also potentially be looking for a focal proximal femoral deficiency. Focal proximal femoral or femoral deficiency. Some basic anatomy. I don't want to go too much into the anatomy on the PowerPoint slides because it's very in-depth, but it's good to know your basic landmarks, but some basic anatomy for the hip. Bones and cartilage, we have this sacroiliac joint. They unite to form the two hip bones with the sacral part in the vertebral column. The symphysis pubis, the pelvic bones, is where the two hip bones unite to each other anteriorly. So hip bones are the fusion three separate bones. Separate bones. Those three bones are going to be your ilium, your ischium, and the pubis. Together, these three form the pelvic girdle. Form pelvic girdle. So we know that the upper thigh bone is the femur. Upper thigh bone. And the upper part of the femur, which is the head of the femur, articulates with the hip bone to form the hip joint. So femur is upper thigh bone, head, articulating with hip bone to form the hip joint. Bone to form hip joint. So these bones ossify at birth. So they start to become hardened, calcified, and the femur is ossified at birth, and sonographically will appear hyperechoic and will cast an acoustic shadow. There's also landmarks that we could use when we're doing this exam, specific cartilaginous landmarks, like the triradiate cartilage. That's a useful landmark, which is lying posterior to the femoral head and appears more hyperechoic and neonate. We also have landmarks of the greater and lesser trochanters. So the head of the femur will appear as a large hypoechoic circle. It may ossify as early as 4 weeks, but typically it's between 3 and 8 months where we have complete ossification. The ossification begins centrally, with girls often showing earlier ossification than boys. So I'm just going to kind of draw what our exam is done in 2 main views. So we have a coronal view and a transverse view. Going to be our femur. And then it's going to form like a little cup coming down. In that area, we're going to have a femoral head. This is our femoral head. In between, we'll have cartilage of the acetabulum. Some cartilage. Acetabulum. Spell that right. Just posterior to that femoral head, where we have that triradiate cartilage. Cartilage. So here I'm carrying more, to me, it's more hyperechoic. You have your labrum. That's another landmark that the doctors will like to see when you're doing it. Labrum. Over here, I'm carrying hypogenic. You're going to have your greater trochanter. Greater. Trochanter. So then we also have some tendons and muscles that kind of hold this all together. So we have our tendon rectus. This can also be called, it's the tendon of the rectus femoris. Then we have the muscles of the gluteus minimus and the gluteus medius, which lie above it. There's a muscle. First one is the gluteus minimus, closest to the bone, and gluteus medius, another layer of muscle above that. So when we're doing our study, our aim and our goal is to align this femur perpendicular to our imaging plane. So if we're imaging with our linear probe, we want this femur to be running perpendicular across the screen. So we want a 90-degree angle from what we're imaging. So we want it going straight across the screen. And then we're going to measure angles. So the machine is set up for us to measure an angle out. And then we're going to measure an angle along here for the acetabulum to see how that femoral head sits within that pelvic. Erase this. So then the other view that we do is our transverse view. So this view is commonly referred to as either maybe like I've heard it referred to as like a champagne glass. Other people have referred to it as like kind of like a seagull. So with this view, we have our femoral shaft coming in. Get our femoral head sitting here. So over here is our femoral shaft. Our head of femur. This section over here is the femoral metastasis. Here we now have our labrum. This bony structure over here is going to be our ischium. And then overlying structures are going to be our gluteus muscles. So you'll see layers of your gluteus muscles. So a couple of terms when we're doing the exam. So we have flexion and extension. So key terms. It's a bending forward. It's a bending backwards. So with flexion, we're gonna bend the leg forward. We're gonna pull it forward. Uh, I'm sorry, push it forward. So we're gonna push it up. An extension is a bending backwards. So we're gonna pull the leg backwards towards you. So the primary flexors of the hip are the psoas major muscle and the rectus femoris. Extension should be limited to 20 degrees. And then we also have abduction and adduction. So adduction, ADD, is moving inwards, moving sideways inwards, and abduction is moving sideways outwards. Abduction. Moving sideways inward. Abduction. Outward. We can also have medial and lateral rotation. So when we're doing our exam, we're going to stress the hip to try and either, exaggerate displacement of the hip, or to rule out displacement of the hip, and or to see how easily that hip is able to displace, put under different stress conditions. So the point of this is to ensure that, the tendons and ligaments are tight and holding the hip in place. So we're doing this because of a condition known as developmental displacement of the hip, or developmental dysplasia of the hip. So it's DDH. So DDH. It's developmental dysplasia. And it encompasses a spectrum of pathologies, which include subulated hip, dysplastic hip, dislocatable hip, and a dislocated hip. So it's a bunch of different conditions. So it could just be a hip that's not sitting properly, within the pelvis, within the hip joint. It could be a dysplastic or a malformed, femoral head or hip. That could be a hip that's able to dislocate and then return back, to its proper location. Or it could be a hip that is actually, fully dislocated. So development of both sides of the neonatal hip requires the femoral head to be seated normally and congruently within the acetabulum. If the femoral head and the acetabulum are not in their normal position, both sides of the hip will develop abnormally. Hip displacement or displacement of the hip is a relatively common abnormality. And when diagnosed in the neonatal period, up to 4 to 6 weeks of age, is often attributed to normal laxicity of the hip. So however, when a dislocation is not recognized early, the muscles tightened and limit movement, which causes the acetabulum to become dysplastic because it lacks the stimulus of the femoral head. In turn, ligamentous structures stretch and fatty fibro tissue occupies the acetabulum, making it impossible to return the femoral head into the acetabulum. So if there is a question, of hip dysplasia, it's important, for these ultrasounds to get done in order to correct the situation to prevent, the permanent damage or those muscles and ligaments tightening and forming, and causing permanent dysplasia of the hip. This fibrofatty pulvinar may also develop in subluxation. It's estimated that there are 1.5 to 20 cases per 1,000 live births of developmental hip dysplasia. And milder forms of displacement, such as subluxation, are more common. All right, some risk factors. A big one is going to be a breech birth. So a breech birth is when the baby is born feet first. As you can imagine, doctors trying to get that baby out, they may be pulling on the feet or the legs and could potentially displace, the femur. Delivery becomes more difficult when there's breech birth. Can also put extra pressure on the hip joints. It's also more common in females. So females affected about 2.5 times more. 5 times more likely. Left hip, 64% of the time is affected, so it's more common. Left side, it's typically unilateral 64% of the time. It's also more common among firstborn children. Common with firstborn. as well as more common with a family history of developmental hip dysplasia. So, family history. So causes of developmental displacement of the hip. The primary root is thought to be increased laxicity within the joint capsule, causing a gradual migration of the femoral head away from the acetabulum. Hormonal, mechanical, and genetic factors are thought to play a role as well. Additional causes, neonatal hip dislocation is often not presented at birth and can be acquired. Teratogenic or developmental. So acquired causes of hip dislocation can be traumatic or non-traumatic. So i.e. neuromuscular diseases. Teratogenic dislocations occur in utero and are associated with neuromuscular disorders. So the clinical examination. So upon visualization, the dislocated hip shows asymmetric skin folds and shortening of the affected thigh. Dislocated hip shows skin folds. And shortening the affected thigh. The knee position is lower on the affected side when the patient is supine and the knees are flexed. So this is called to as referred to as the Galeazzi sign. Galeazzi sign, sorry. So when knees are flexed, knee appears lower. Affected side. Let's call this GALEA. ZZI. Release sign. So you can imagine kind of like the baby's lying supine, you flex the knee up, you have both knees flexed up, The affected side, the knee is going to appear lower down because that hip is displaced. So here you could see the folds, and how the knee appears lower on the affected side. So another thing to remember too is that female hormones allow for hip instability as part of the birthing process. So these babies are born flexible and bendy due to these maternal hormones. So another thing to consider is that hip instability may resolve after 4 to 6 weeks due to waning maternal hormones. So hips may become stable after 6 weeks due to waning maternal hormones. Therefore, neonates with slightly positive or inconclusive physical exam and newborns with a risk factor for DDH should be examined with sonography after this period to reduce false positive results. So we usually don't like to do these hip ultrasounds until the baby's at least a month old or at least 4 weeks old, because we can get a false positive result because they're so loose and moving and flaccid. You know, the tendons and ligaments are very loose. So it would be easy when we're stressed, you know, to create hip dysplasia when we stress the baby's hip. So wait. So after this period to minimize false positive. There are 2 basic maneuvers which are helpful in diagnosing developmental hip dysplasia. The first is the Barlow maneuver. So maneuvers. Maneuvers. CDH versus Barlow. So Barlow maneuver determines if hip can dislocate. And the second is the Ortolani maneuver. So Ortolani maneuver determines if the dislocated femoral head can be reduced back into the acetabulum. Dislocated hip. Be returned back to acetabulum. So this is our Barlow maneuver. So a patient is supine. The hip is flexed 90 degrees. So you bring the hip up, you create a 90-degree angle, and then abducted outward. And outward pressure is applied. So you bring it inward. And then with the Ortolani maneuver, patient is supine. The examiner's hand is placed around the hip to be examined, and the fingers over the femoral head. Examiner's middle fingers lie over the greater trochanter, and the thumb over the lesser trochanter, and the hip is flexed 90 degrees and then abducted, brought inward. I'm sorry, outward. So this isn't something that you guys are going to necessarily be doing. This is, done by the doctors, the pediatrician, or the nurses, to check when the new baby's born or when they go for their physical. So sonographic evaluations, again, where our primary indication is presence of risk factors for developmental displacement of the hip, abnormal hip examination. So if they hear a hip click, so when their babies are born, they'll perform these maneuvers, this Barlow maneuver and this Ortolani maneuver. If the hip does dislocate, particularly this Barlow maneuver, if they hear a click, that could potentially be an indication, as well as evaluation of response to treatment. So if a patient or a baby does have hip dysplasia, they're going to place them in a harness and try and reset that hip and allow those tendons and ligaments to strengthen over a properly placed hip. So we'll do follow-up evaluations to evaluate the response of the treatment. So the exam can be performed until the femoral head, completely ossifies. And we said ossification of the femoral head begins between 2 and 6 months of age, occurring earlier in girls, and is often completed by 1 year of age. So exam. So this is where we come in now. So, this patient's baby's been evaluated. They have risk factors. Say they were breech birth. During an exam, maybe the doctors heard a hip click or they noticed some of these signs. There's one leg appears longer than the other, knees lower. They see those skin folds. They're suspecting the possibility of a hip dysplasia. They'll come to our ultrasound department for the hip examination. So, you want to make sure that, first off, the baby is relaxed and comfortable. It's going to make your test a lot easier. These babies don't have to be NPO, so they're able to feed, so encourage feeding before the exam. Make sure your room is nice and warm. You have your blankets, nice warm gel. You could potentially have, toys, or mother can bring toys to distract the baby. Parental assistance is often useful too, so you don't have to kick the parents out of the room. They can lie on the stretcher next to the baby, try and keep them calm. So exam, so transducers. So in my lab, we used a high frequency linear probe. Frequency. We actually used an 18 megahertz linear probe. So it was a really super high frequency. A lot of labs might use a 12 to 15 megahertz. So that's particularly true of premature babies. As the baby ages and as that femoral head begins to ossify, you may have to use a lower frequency. So you may have to drop down, to like 7.5 to 9. As baby ages. And this could go all the way down to as low as 3 megahertz after 7 months. Just always remember, start as high as you can and work your way down, because your highest frequency transducer is going to give you your best resolution. And the doctors want their nice, pretty pictures, and it'll help you to visualize the structures as well. So position. Supine. This. I prefer supine. For me, it's just easier. Decubitus view. You can roll some towels up underneath the baby's back to keep them turned. There are specialized cradles that may also help keep the child on the side. The sonographic examination for a DDH evaluates the degree to which the femoral head is covered by the labrum, as well as the position of the femoral head in the acetabulum at rest and during motion and stress. Throughout the examination, the sonographer is able to assess the position and stability of the femoral head, in addition to assessing the development of the acetabulum. The stability of the hip is determined through guided motion and application of gentle stress. So the first view we're going to do is our coronal view. Then we have our perpendicular femoral shaft. And we'll have our acetabulum coming down. From the head. You want to be able to also visualize your labrum. Trochanter. So like I said, so when you're doing your exam, that's the view you really want to get, focus on trying to get a good picture with your labrum in the picture. And then what you're going to be doing is you're going to be measuring angles. So you're going to take your caliper and the machine's going to be set up for doing these hips. So it's going to be able to calculate angles for you. So you're going to put your first angle, you're going to have your line parallel to your femoral shaft, and you're going to extend it out, into the femoral head. So you want to make sure that, your line is parallel to your femoral shaft. And then you're going to have another caliper that you're going to line up another line. You put a caliper into the acetabulum, and you're going to extend it upwards. And you're going to try and calculate the angle between the femoral head and the acetabulum. So we're looking for angles that are greater than 60 degrees. So we want greater than 60 degrees, normal. So between 43 and 60 degrees is considered mild dysplasia. And less than 43 degrees is severe. So if there's an issue with hip dysplasia, what's going to happen is that angle is going to start decreasing, and this hip is going to be lying shallow within that femoral head. it's going to start rotating out. So your angles become less and less. So this is going to start becoming less and less. So we're going to stress the hip. So we're going to do stress maneuvers, performing abduction and abduction. Also capture stress images. So we'll do image, normal, resting. So we'll image, relax, and we'll image, stressed, abduction, abduction. So we're going to move that hip out. We're going to move that hip inward, applying gentle pressure to see if that changes our angle. We're also going to perform flexion and extension. Extension. So we're going to do with the, we'll have the baby in a resting position. Then we're going to extend the leg out and do flexion, bring the knee back in, and require images with flexion and extension. Then we're going to also perform our transverse view. So in our transverse view, there aren't any measurements that we have to require. We're just performing stress on the hip to try and visualize that the hip sits nice and low. So again, so we're looking to make sure that the femoral head is sitting low within our within the metastasis and the ischium. So again, you also want to try and visualize your labrum. This is our femoral shaft. That's femoral shaft. This is our femoral metastasis. This would be our ischium over here. So with this view, we're doing our abduction. Abduction. Some labs will actually have you do a cine clip while you're stressing. So when you're rotating the hip outward and inward, you're looking to see if this hip shifts out and up out of this groove. You can also assess if it's a low-lying hip, so it should sit nice and flush within that groove. So the relaxed position is called a neutral view. This is our neutral coronal view. So we have the probe. It's in a sagittal orientation, but it's called a coronal view because we're coming from a coronal angle. So we're lateral on that baby's hip. So this is going to be your neutral view. And then with flexion, we're bending the knee up. And extension, we're pulling it forward. So this would be with flexion. So we put gentle pressure to see if that angle changes with our coronal view. Then we'll extend the baby's leg out to see if there's change in the angle. We can also abduct, bring outward, or adduct, bring inward. So with our coronal neutral view, the plane must demonstrate a straight iliac line to the inferior tip of the ostium or the ilium bone, the midpoint of the acetabulum. The hypoechoic cartilage of the acetabular roof extends lateral to the acetabular lip. The echogenic tip of the labrum should also be visualized. So it's important, try and visualize that labrum. So the coronal flexion view is also made at the mid acetabular with similar sonographic features. That's a coronal neutral view. However, it's unlike its neutral counterpart, the echogenic femoral metastasis is not visualized in the coronal flexion view. So this is also the coronal flexion view provides more of a ball and spoon appearance. So that's commonly what it's referred to. So remember some of your other landmarks, your gluteus medius muscle. So there's your gluteus medius muscle. It's your bone of your acetabulum, your femoral head. So this is a good example of a dislocated hip. So you could see your hip, the femoral head is not sitting down in that groove. So your acetabulum and your iliac, your ilium, your femoral shaft. So if I was to, measure out and do my angles, This will definitely be less than 60 degrees. Then we do our transverse study. So transducers rotated 90 degrees and move posteriorly to a more posterolateral approach. So we're coming a little bit more posterior. So we rotate 90 degrees. So this would be our transverse flexion view. So we get that U-shaped configuration. Again, some people refer to this kind of like as a champagne glass appearance. This is your metathesis, your femoral head, your ischium, labrum over here. So you're looking for the femoral head to sit nicely within, this groove, within this U. So if you see a femoral head that's elevated or raised, that would be an indication of dysplasia. And we look for changes when we're doing stressing. So abduction or more V shape is seen, while a deep U-shaped configuration is produced with maximal abduction. So this is just a picture, showing stress. Again, you could see this would be normal. Nice femoral head is sitting down within that groove. So be careful that your transducer is posterior enough to image the medial bony acetabulum, or the hip may appear falsely displaced. The hip is then stressed with a gentle posterior push or adduction. This is that Barlow maneuver, so pushing inward. In the normal hip, the femoral head will remain deeply in the acetabulum and in contact with the ischium with stress. So when we abduct, we're going to maintain contact with the ischium during stress. Again, this is a good picture showing that U, femoral head sitting deep within that, maintaining contact with the ischium. In the transverse view, if subluxation is present, the hip will normally be positioned or mildly displaced at rest, and there will be further lateral displacement of the medial acetabulum with stress, but the femoral head will remain in contact with a portion of the ischium. So if the femoral head dislocates laterally, the center of the femoral head does not line up with the iliac wing. Draw a line through the iliac wing. A line drawn through the iliac wing will pass through the medial aspect of the femoral head. If the femoral head dislocates posteriorly, only an echogenic arc, which represents one side of the head, is seen. With a frank dislocation, however, the hip will be laterally and posteriorly displaced to the extent that the femoral head has no contact with the acetabulum, and the normal U configuration cannot be obtained. With abduction or Ortolani maneuver, the dislocated hip may be reduced or returned back into the acetabulum. So here you go, is our normal presentation. And then this would be our transverse view with the displaced hip. So you can see lack of contact with the ischium over here. Just want to show you this, guys. So treatment and sonographic follow-up. So most important factors influencing the outcome of DDH is the age at which diagnosis is made and treatment is initiated. So treatment should begin before patient walks and ideally long beforehand. Initial treatment of uncomplicated DDH is closed reduction. This is accomplished by placing 2 diapers on the neonate or by using the use of a Spica-Cast brace or a Plavix harness. The hip should be positioned in flexion with the abduction and external rotation. All right, so let me show you guys what this harness looks like. So this is the harness that they typically put these babies in, that they'll come to you if they have a known history of dysplasia. This is called a Plavix harness. It's important when you have these patients are going to be outpatients. When they come in, you make sure that the script says that they want the test either done in or out of the harness. So the doctors will specify, specifically if they want the test done with the baby in the harness or if they want the test done with the baby out of the harness. So don't just assume, verify with the doctors whether or not they want the test in the harness or out of the harness. The position of the femoral head relative to the acetabulum can be determined with follow-up sonography. If the patient is in a cast, a window must be cut into the cast so the transducer can be placed directly on the skin. That's obvious. Fortunately, the Plavix harness is more commonly used, allowing for easy access to demonstrate the hip joint's response to treatment. Within 6 to 8 weeks of treatment, the hip joint often stabilizes. So this could be an example, of a baby that was diagnosed with hip dysplasia. So you can see that angle definitely looks like it's less than 60 degrees. And then when they're followed up in the harness, you can see that the angle now appears normal. So if we draw our lines, this looks like, definitely greater than 60 degrees. So what that transverse one look like. So we can also have joint effusions of the hip. So joint effusions can occur when synovial fluid builds up in the hip capsule. So this could be a transient thing or suggest septic arthritis. In order to determine if it's septic, they would have to actually take a little sample of that fluid. So sonography offers a rapid, sensitive technique to detect joint effusions of the hip. If a joint effusion is present, synovial fluid needs to be aspirated or arteriocentesis, and this is often performed under sonographic guidance. So this is going to be done under the guidance of your interventional radiologist or an MSK radiologist. So this was kind of that MSK that I was showing you here in the lab with these hip ultrasounds to rule out effusion. So again, this is going to be our femur or shaft of our femur or femoral head. So we're looking for effusions in this space. So again, we would line the babies up, have their legs perpendicular, straight out, toes up, nice straight legs. And we align our transducer parallel to that femur at the femoral head. So this would be an example for our right hip. You see a little fluid within the space here. This is the left side showing no fluid. So this is a normal hip. So some other conditions or differential diagnoses. It could be a rhabdomyosarcoma, osteomyelitis, myositis, cellulitis, abscess formation, or proximal focal femoral deficiency. So these hip effusion ultrasounds are easy. So if I'm doing this, if I see any indication of fluid, I'm going to put my power Doppler on here to see if there's also hyperemia within the tissue, because if it's an infective process or a septic hip, you'll typically have hyperemia, which would be evident by putting power Doppler on. So I'll see if there's color flow in that area. So any questions about this ultrasounds? They're not too bad once you start doing them. Just got to be quick on, the freeze and like capturing your images. It's a lot of sitting, looping back. You need two hands on the baby, so it can be a little bit tricky. But they're not terrible. It's not a lot of pictures. You're doing your coronal images, relaxed, with flexion, extension. You can also abduct and adduct. In the transverse view, you're going to do your abduction and your adduction to see if there's displacement of the hip. Your angles, you want your angle greater than 60 degrees. You want to make sure in the transverse view that the femoral head is sitting nice and low within that U-shaped cup and has contact with the ischium. And oftentimes the pediatric radiologists are going to come in. A lot of times they'll be present for these exams. Sometimes they may want to scan them themselves. So again, it all depends on your lab and your situation. And I will see you guys at 10 o'clock. All right.
Thank you.
Welcome.
Thanks, Ann. Bye.
Bye.